Okay, I think we can get started here. It's my pleasure to introduce today's Grand Round speaker, Dr. Michael Haffner from the Fred Hutch Cancer Center. Dr. Haffner received his MD and PhD degrees from the Innsbruck Medical University in Austria. He performed postdoctoral fellowship training at Johns Hopkins University, where he also did his residency and fellowship training and was a junior faculty member there. In 2019, he was recruited to Fred Hutch as an assistant professor and also assistant professor in the Department of Pathology at the University of Washington in Seattle. And then last year, he was promoted to associate professor in the Department of Lab Medicine and Pathology at the University of Washington in Seattle. Dr. Haffner is a very well-known GU pathologist who's made seminal contributions to the field. He's won numerous honors for his work. In 2010, he was awarded the Johns Hopkins Postdoctoral Association Award. In 2012, he received a Young Investigator Award from the Prostate Cancer Foundation. And in 2021, he received the American Society for Clinical Investigation Physician Scientist Award and a Doris Duke Clinician Scientist Award and a V Foundation V Scholar Award. And I'm really excited that he's here today to tell us about his research. And his seminar title will be From Diagnosis to Precision Medicine, the Evolving Role of Pathologists in Prostate Cancer Management. Michael, the floor is yours.
Scott, thank you so much. Let me just make sure I get this started right.
Looks good on my screen.
Perfect. Excellent. Well, thank you so much for the invitation. It's really a great pleasure to be here with you today and share some of my thoughts on the evolving role of the pathologists. And these are my disclosures. But what I really want to do today is give you sort of a little bit of an overview of where we stand and where we potentially could go in terms of diagnosing advanced metastatic prostate cancer. But I want to start a little bit with a background on prostate cancer. Many of you know it's a very common disease, almost 300,000 new cases diagnosed. And then about 35,000 men die in the United States of advanced metastatic prostate cancer. What's interesting about the disease is that from the initial diagnosis to then the disease-related deaths, there's often a very broad span of time where patients undergo multiple rounds of therapy. And a lot of our patients live with metastatic prostate cancer. So here are just a couple of numbers. More than 200,000 men currently live with metastatic prostate cancer in the US alone, and worldwide that's 1.5 million. And I would make the argument that in pathology, we've been mostly focusing on the diagnosis of primary disease, whereas metastatic disease has been pretty much an untouched field of detailed studies. And this is the space where I want to provide a little bit more insights in the next couple of minutes. Again, to back this up, I really think that the field of GU pathology has done a tremendous job over the past decades in classifying localized disease. And what still is a big surprise to me that this initial grading system developed by Donald Gleason is such a robust way of classifying tumors and prognosticating, where a biopsy taken many years before the onset of disease progression can already show features of adverse biology. And this is really very unique, and I think prostate cancer stands out in having a grading system for primary tumors that is so robust. But the big challenge I think that we're facing right now is what about metastatic disease? Can we push the needle forward in terms of the insights that we can gain from a pathology perspective in the context of patients with more advanced disease? And I think in order to understand the biology of advanced metastatic prostate cancer, we really have to think about drivers. And the most relevant driver of the disease is the androgen receptor. And it's not surprising that over the past decades, numerous different ways have been developed to inhibit androgen receptor signaling that starts at inhibiting the production of androgens, now down to more sophisticated competitive inhibitors of the androgen receptor. And this has all led to a major change in the way that the disease presents itself in patients. So most patients with metastatic disease are treated with androgen deprivation therapy. That's a form of chemical castration. And while this is effective in many patients, most patients show disease progression and enter a disease stage that we call castration-resistant prostate cancer. And in this context, these newer androgen receptor pathway inhibitors can be deployed, which again show initial responses, but then progression. But what's been very interesting to see that in the context of the use of these newer, highly potent ways of inhibiting the androgen receptor signaling axis, the disease has changed in its phenotype. Whereas conventional prostatic adenocarcinomas are known to express the androgen receptor. They express downstream targets of the androgen receptor that we can measure, such as PSA or very well-established biomarkers, but they're usually negative for markers that show neuroendocrine differentiation, such as synaptophysin and chromogranin. But again, over the past decade, with the increasing use of these more potent inhibitors of the androgen receptor signaling axis, we've seen a dramatic shift, and this is documented here, where more and more patients present after therapy with what we call neuroendocrine prostate cancers, or NEPCs. These tumors lose the androgen receptor and downstream neuroendocrine receptor pathway genes, but gain the expression of neuroendocrine markers. Or there's this other flavor of prostate cancer that's increasingly recognized that as known as double negative prostate cancers, where you see lack of androgen receptor expression and also lack of neuroendocrine differentiation. So a true shift in the composition and molecular phenotypes that we appreciate in this advanced disease setting, potentially associated with the use of more effective therapies that target the androgen receptor signaling axis. Now, this has, I think, major changes for us in pathology practice, because more and more patients are now undergoing metastatic biopsies. So what are the indications for metastatic biopsies? At least in our center, a lot of patients get metastatic biopsies because there's a suspicion for one of these converging phenotypes. You also get metastatic biopsies to perform genomic testing to confirm a diagnosis and for clinical trial enrollment. And I have to tell you, in the past 2-3 years, the number of metastatic biopsies that we've received in our service, that includes both patients from our hospital system as well as consultation cases, have really dramatically increased. And what we've learned is that in the metastatic disease setting, under the microscope, metastatic prostate cancer just looks very different, even though we can still appreciate some adenocarcinoma morphologies. But we also start to appreciate that there are histopathologic features that are usually very, very uncommonly seen in localized disease. That includes tumors with overt squamous differentiation, also tumors with these pleomorphic giant cells shown here to the right, and then tumors with frank small cell morphology. So the spectrum of histomorphologic features that we can appreciate in this advanced metastatic setting is very diverse, and I think calls for a different way of classifying the disease. At the same time, there have also been a lot of different classification approaches on the molecular level. And here I'm just showing you a study from my colleagues, Colin Morrissey and Pete Nelson, using RNA sequencing technologies to classify prostate cancer in a very simple way, just based on the expression of androgen receptor signaling pathway readouts and neuroendocrine differentiation markers. And in doing so, you can group advanced metastatic prostate cancers into 4 different buckets. those that are androgen receptor positive and show no neuroendocrine marker expression, these are still luminally differentiated and have a retained caricature of a prostatic adenocarcinoma. Then we have these tumors that lack the androgen receptor activity but have gained neuroendocrine differentiation. These are not commonly known as neuroendocrine prostate cancers or NEPC. And these have very aggressive disease behavior. Then we see other tumors that have either a co-expression or an intermixed expression of cell populations that are positive for androgen receptor markers as well as neuroendocrine markers. And then lastly, and we talked about these before, we see tumors that lack the activity of the androgen receptor and downstream androgen targets, as well as neuroendocrine differentiation, so these double negative tumors. What's really important, I think, to note is that this separation in these four buckets seems to be very much tied to underlying epigenetic changes, because irrespective of what kind of profiling methodology we use, may that be chromatin accessibility studies using ATAC-seq or DNA methylation studies, we start to see these four groups emerging in our molecular analysis. And of course, this is also associated with differences in clinical outcomes. I already mentioned that the AR negative neuroendocrine marker positive tumors have the most aggressive disease biology, closely followed by these double negative tumors. So there is a great value in thinking about these concepts, both from a research but also from a clinical perspective. Now, what's been very challenging is taking these molecular studies that necessitate global transcriptomic analysis and bringing them into the clinic. And we've done a lot of benchmarking work trying to identify what are simple IHC markers that can be used in every diagnostic laboratory that would give us a readout for these molecular subtypes. And the summary of all this led to a very simple set of markers: the androgen receptor and NKX3.1 to read out AR activity, synaptophysin and INSM1 to neuroendocrine markers to determine neuroendocrine differentiation, and then Ki67 is a proliferation markers. And in context, these five markers together allow us to very robustly classify any biopsy material according to these four subgroups that I had introduced to you. But I think broadly, there's this urgent need in having a better classification for castration-resistant prostate cancer. Morphology or IHC in isolation might be insufficient, and we need to define diagnostic criteria and the terminology that the field broadly can apply and agree upon. Because the standardization of terminology will not only impact clinical management, the interaction with our clinical colleagues on one hand, but then also the exchange of information across different providers and treatment centers, but will also allow us to design clinical trials specifically for these molecular phenotypes. So in order to think more broadly about this challenge, we brought together a group of experts covering both pathology, medical oncology, and urology to really take a deep dive and think what would be the best way of classification of these tumors. And we were very much inspired by the emerging literature from other solid tumors, where, think about breast cancer, for instance, you no longer say breast cancer as a primary diagnosis, but you say invasive ductal mammary carcinoma, so a morphology diagnosis, and then you add biomarkers, ER positive, PR positive, HER2 negative. So we really felt that there's an opportunity to potentially use a similar classification approach also for advanced castration-resistant prostate cancer biopsies. And this is a framework paper that was just recently published. And I just want to quickly walk you through that classification approach, with the goal of it being that we wanted to have a very, very simple framework that can be applied in any diagnostic laboratory. And we want to integrate both morphology classifier, an IHC-based classifier, and a classifier that relates to proliferative activity of the tumor. So how would that work? We would look under the microscope and assess the morphology in very broad terms. Is there adenocarcinoma? Is there gland formation? Is there no overt gland formation? We call it a poorly differentiated carcinoma. Are there features of overt small cell carcinoma, or are there other morphologic features that we can determine, such as squamous differentiation? Then we would use the IHC-based classification that I had introduced to you, splitting the tumors in those that are AR positive, AR negative, neuroendocrine marker positive, neuroendocrine marker negative, and then classifying the tumors as well based on their Ki67 positivity. And then the diagnostic lines would be very simple and descriptive. Prostatic adenocarcinoma, for instance, AR positive, neuroendocrine marker negative, Ki67 20%, or in the context of a small cell carcinoma, AR negative, neuroendocrine marker positive, Ki67 of 70%. So this is a very simple framework that we hope will provide a useful way of guiding the diagnostic approach, but also then allowing to layer on additional biomarkers that might relate to specific predictive tests that are performed. Now, what I want to also highlight that we strongly advocate that this current framework should only be used in the context of castration-resistant prostate cancer, and further studies are needed to see whether in other disease settings such a classification framework would be of value. But maybe there's more to this, and maybe there's a little bit more of a nuance, in particular as we look for these differences in morphology. And this is unpublished work done together with my colleague Cornelia Dehm, a faculty member at UCSF, and Jane D'Souza, who's currently a resident at MGH. And what we started to do is try to take a much broader look at the morphologies that we appreciate in castration-resistant prostate cancer, and classify them into 14 different morphologic features that we were able to recurrently determine in our case series. And there were some findings that were particularly interesting. So this is a cohort from the University of Washington Fred Hutchinson Cancer Center of 251 men with metastatic biopsies. And what I'm showing you here is a Kaplan-Meier curve broken down by the individual morphologic features that we observed in the metastatic biopsy material. And there were a couple of big surprises for us. The first one was that tumors with cribriform adenocarcinoma morphology appeared to show the most favorable outcome in this cohort. Conversely, tumors that showed squamous differentiation, or that showed these large pleomorphic giant cells, had very, very poor outcomes, very similar to what we've seen with tumors with neuroendocrine differentiations, or NEPCs. So this really shows that just looking at very crude morphologic features can give us a potential clue in the biology. It also, I think, calls out these challenges that these morphologies have to be interpreted in a context-dependent manner, because as many of you know, the literature in localized prostate cancer has demonstrated over the past 10 years very nicely that showing these cribriform structures and cribriform morphology in general, particularly large cribriform glands, is in the localized disease setting associated with poor outcomes. In the metastatic disease setting, now we see the complete inverse, again, suggesting that these disease settings require a more refined and nuanced approach, and morphologies can switch in their biologic relevance from primary tumors to metastatic sites. But in parallel, I think there's also this tremendous evolution in our field. And I would make the argument that over the past centuries, the field of pathology has made very steady progress. But right now, we are at this major inflection point. And this is really majorly driven by the advent of two technologies that come together. One is the ability to digitize slides and have robust digital images of all of our specimens available. And of course, in parallel, the evolution in computer science and the ability to use deep learning and AI to extract image features and analyze them. The reason why I think this is so important is because it allows the field to switch fundamentally from a qualitative and descriptive discipline. Think about Rudolf Virchow's studying for many, many decades, trying to appreciate nuanced features that you can see on the slide. And this is, again, a knowledge that is very much difficult, subjective, and very difficult to communicate in many ways. Now switching over to the practice of pathology where we have truly quantitative readouts from all different features that we can appreciate on a slide. So this transition from a qualitative to a quantitative discipline, I think is exceptionally important, and I think will hopefully propel the way we diagnose in the years to come. And I think for many of you, this is not a surprise, but just looking at a diagnostic slide, we see a whole lot of information in front of us. Most of this information is not really captured in our diagnostic reports. And I think a lot of highly valuable data is not really well codified and therefore not communicated in a way so that it informs clinical decision making for our clinical colleagues. So the central hypothesis is for us really that a deeper morphologic analysis will provide additional insights into disease biology and will allow us to develop quantitative biomarkers in the correct clinical setting. So I wanted to talk to you a little bit about emerging digital pathology tools that our group has developed for a more precise classification of metastatic prostate cancer. And when we think about the application of these AI tools in pathology, we can break them into two separate groups. One is just assist with standard diagnostic tasks. Is there tumor? Is there no tumor? But I think even more interestingly, we can think about providing additional relevant clinical information through these approaches that might guide clinical decision making in a new and unprecedented way. I have to fully admit I am not a AI expert, but I had the great pleasure to work with a wonderful group of individuals, in particular Stephanie Harmon, who's a machine learning expert at the NCI. And together with Stephanie, we've brought together a group of investigators covering both pathology, urology, statistical modeling, medical oncology, and other disciplines to work together with us on questions related to AI model development in the context of advanced metastatic prostate cancer. And again, it is this very collaborative and interactive approach that is, I think, absolutely needed for these type of studies. So how do we usually approach the development of such deep learning frameworks for diagnosis and prognostic models? Everything starts with a whole slide image. Again, these days, this is very easy to generate using the whole slide scanning capabilities that are available. And then there's a lot of processing that goes into these images. We need to detect the individual tissue elements on the slide, detecting cancer elements on the slide directly, but then also detecting potential artifacts that come from sectioning and staining. So a lot of pre-filtering is necessary. And in the next step, we want to extract individual features from the slides. These can be done by convolutional neural network-based approaches, such as foundational models, using standard architectures, custom architectures, or to just use handcrafted models that extract a very defined set of features, say, for instance, the size and shape of the nuclei that we see under the microscope. And we have a learning framework. And this learning framework can either be based on individual tiles, small segments of the image, or can integrate multiple of these tiles together. So we speak of instance-based or multi-instance based learning. And then we have an output prediction, and that can be a multi-class, multi-label, or a regression model that eventually then uses the image features and predicts a certain defined outcome from the image features available. The other thing that's really important, and again, coming back to this highly collaborative aspect, is to build multi-institutional cohorts for biomarker testing. Here, I'm just showing you some of the cohorts that we put together for the training and development of prognostic models in the context of castration-resistant prostate cancers with specimens from the NIH, from the University of Washington, Fred Hutchinson Cancer Center, from UCSF, and from the Cleveland Clinic, being used together both in a training and test context, but then also for external validation. So for these models, again, what I want to emphasize is the importance of quality control and this important aspect of having still an expert pathologist in the loop. So the way we devise a lot of our models, particularly in the early training phases, is that we use image-guided methods that allow us to visualize where model activity occurs in the slide. And this is shown here in the top, where model predictions in this particular case, just for cancer detection, is highlighted with the heat map shown in the middle micrograph. And then the path that we've been taking is that pathologists trained in geopathology go in and reevaluate these calls of the individual models. Here's a postdoctoral fellow, Eric Kansayar, who's finished his pathology training in Turkey and then joined us for a postdoctoral fellowship. And having these pathologists in the loop is so extremely important to ensure that in early model development, the calls and the detection of relevant cell population is accurate. So for predicting outcomes now from castration-resistant metastatic biopsies, this is the model framework that we've been applying, again, using a deep learning model for detecting individual cancers, then using a previously published foundation model to extract distinct image features. And then we applied a novel attention-based machine learning framework that was developed by our group previously to predict the outcomes based on image features and the likelihood for prostate cancer-specific death within the first 3 years. So I'm here showing you the Kaplan-Meier curves of these model outputs from the holdout test set. And you can see the high-risk group shown in red shows inferior overall survival compared to the low-risk group. But the big issue, again, with all of these models is that developing them in the context of one clinical cohort is not good enough. You really need to validate these findings in external cohorts, and this is done here. It's a completely independent external cohort from the Cleveland Clinic that we had access to. Using the locked-in model on these external images revealed a very similar split in outcomes. And this is giving us a whole lot of confidence that the model outputs are really generalizable. A lot more additional validation in external cohorts is necessary. But I think it's established here a framework for identifying features that are strongly associated with clinical outcomes. But we want to go a little bit deeper and also understand what do these features really mean in terms of their molecular associations. So in this case, we used a large set of H&E images from a rapid autopsy cohort. I'm going to introduce that next couple of slides to you in greater detail, where we have image but also RNA-seq information available. Then we classify these images based on our outcome predictor, and then we perform differential expression between the favorable and unfavorable group to identify transcriptomic differences between these morphologically defined groups. And this is what we found, and it's very encouraging that if we compare the morphologically defined high-risk tumors with the low-risk tumors, we're starting to see that just in pathway analysis, there are a lot of changes that biologically make a whole lot of sense. For instance, in the high-risk group, we see a much higher activity of gene sets that relate to cellular proliferation, including those that are associated with G2/M checkpoint, mitotic spindle, and others. Whereas gene sets that relate to a more differentiated cell state, such as those that associate with androgen receptor signaling, are greatly reduced. This really suggests that these morphologic features that we're reading out in this model are anchored in an interpretable biologic context. Maybe even more interesting, we also start to appreciate that within these high-risk, low-risk groups that we can define based on morphology, we see differential expression of certain druggable targets that could potentially lend themselves for a more refined and morphologically informed therapy. The other project that I wanted to show you quickly is one that's focused around identifying particular subclasses of castration-resistant prostate cancer, in particular, those neuroendocrine prostate cancers. And we've already talked a little bit about the challenges of diagnosing neuroendocrine prostate cancers and the necessity of having IHC as sort of the gold standard to help with the diagnosis and assess expression of neuroendocrine markers. But we thought maybe there's an opportunity for us to train a model that could simply, based on H&E features, robustly detect neuroendocrine differentiation. So we did this again using samples from our local rapid autopsy cohort. More than 3,600 images were used. And the important aspect here is that for each H&E image, we also had matching IHC studies performed, allowing us to have this IHC gold standard built in. In addition to IHC, for many of these cases, we also leveraged RNA-seq data to build this model that we called NeuroPCA, or again, similar framework that I outlined before. We take whole slide images, then select cancer-containing tiles, and then through a custom encoder system, as well as an attention-based deep learning framework, we predict the probability of neuroendocrine differentiation. And the model then generates, on a tile-based level, a neuroendocrine score that ranges from 0 to 1. We perform benchmarking studies using this model in different cohorts, and we've seen excellent performance with an AUC of 0.92. And here I'm just showing you a couple of representative images. And again, this aspect of having an opportunity for additional expert control and learning, where for all of these models, we have a graphical output. You see this on this NeuroPCA heat map, where we see the likelihood of neuroendocrine differentiation superimposable on the H&E images. And you see dramatic differences here in a neuroendocrine case versus a non-neuroendocrine case, and the confirmatory IHCs on the side. So again, always allowing us to visualize where the model activity takes place. Can also then take these model readouts back to what I'd shown you before and cross-correlate model activity with RNA sequencing output. And clearly, we see in those tumors with high model predicted neuroendocrine scores, here shown in orange, that a large number of genes associated with neuroendocrine differentiation is highly expressed, and this is also recapitulated in the heat maps showing on the right, where there's a clear gradient between the cases that show high prediction of neuroendocrine differentiation by our H&E model, and then the underlying transcriptomic changes shown here are gene sets that relate to the activity of androgen receptor signaling as well as neuroendocrine neuronal differentiation. So again, a tight interaction between what we see morphologically, what we can measure now quantitatively morphologically, and what we think is going on in terms of the underlying biologic changes. The other thing that we notice is that because the output of this model is a quantitative one, we can use now the quantitative readouts, dichotomize them, and use this particular approach also for prognostication. So here I'm showing you a cohort from our own institution. This is a mixed cohort of tumors with frank neuroendocrine differentiation and adenocarcinomas. And here we're applying the models, categorizing them in high risk and low risk based on model output scores. And you can clearly see that we can split the curve. But even more interesting, in a separate cohort from Weill Cornell, where all of these tumors were clinically described as neuroendocrine prostate cancers, the activity of the model further refines the prognosis of these tumors. And then in yet another independent cohort from MD Anderson, applying the model to a set of patients with advanced prostate cancer show aggressive variant features, we can see that higher model scores are associated with adverse prognosis, and concert really suggesting that this refined way of looking at neuroendocrine differentiation not only allows for more accurate diagnosis, but in this more nuanced way also allows for prognostication. So maybe another aspect that we were very curious about is, can we identify certain underlying genomic alterations from H&E slides? And this is work done together with my colleagues Colin Pritchard and Eric Connick, and really driven by a very talented postdoc, Lucas Liu, and leveraging a whole different set of specimens where we have detailed, annotated genomic calls available and the matching H&E images. And Lucas then developed another model predicting the likelihood of certain genomic alterations. Don't want to go too much into detail, but just show you some of the actual data in now using holdout test sets for this study and predicting clinically relevant alterations in the androgen receptor, the tumor suppressor P10 and P53, as well as genes that are associated with microsatellite instability. And you see here that the RC, AOC values are favorable, with ranging from 0.7 to 0.86, with very high sensitivities, in particular in being able to detect microsatellite instability or mutations in MLH1, MSH2, MSH6, and PSM2. And the reason why we think this is really important is that prostate cancer is known to be a Lynch syndrome associated disease. So this would allow us, with a very simple pre-screening test, just leveraging the existing H&Es, to potentially triage patients for further genetic testing. And of course, there's a whole lot of interest also in potentially screening out patients that would benefit from immunotherapy in the context of mismatch repair deficient prostate cancers. So where do we see this going in the future? I think we'll still probably start with an H&E slide. But I think that there's going to be a great opportunity to leverage these AI systems as pre-screening tools to maybe identify areas of neuroendocrine differentiation, highlight potential alterations that might be present in the tumor. But also, this is a field of intense investigation. We can extract many, many other features from these tumor slides. And it's not about really replacing the pathologist at the end, but enhancing the ability of the pathologist to see and accurately diagnose clinically relevant tumor features. So where do I see really the major benefits from digital pathology and AI in the future? I think for the first time, we're seeing that these technologies are a major innovation in the field of anatomic pathology. I think they're great opportunities for improvement and clinical diagnostics, but all of this also is tightly related to a lot of the research work. And I think what's probably most interesting is now that we can extract highly quantitative data from pathology slides, this lends itself to the more integrated analysis approaches where we take pathology, radiology, and then other data that we can extract from clinical health records and integrate them together. But I think most importantly, I think just using existing H&E slides to extract more relevant molecular information is probably one of the most cost-effective ways of precision medicine. And I mean, something where costs can be saved for healthcare systems while still maintaining a very high level of accuracy. So in the last couple of minutes, I just want to end on a couple of thoughts how pathologists can be involved in developing new therapeutic strategies. And this is mostly driven by this increased interest these days in targeting cell surface proteins that are specifically, or at least in higher levels, expressed on cancer cells. Because the framework that's been established over the past decades of being able to use different binders, maybe small molecules or antibodies that can specifically then bring a payload or warheads to cancer cells by binding to these cell surface protein is a very attractive way of cancer-directed therapies. Of course, we can have different binders, as I alluded to, but what's also, I think, very important is that these binders can now be loaded with different payloads. And there are multiple different options. You can, for instance, bring radionuclides to cancer cells, delivering target-specific radiation. You can bring certain highly potent drugs in the form of antibody-drug conjugates, or you can also increase the influx of immune cells into the cancer microenvironment. This can be done by so-called bispecific antibodies that bind to one arm the cancer cell and the other arm a T cell, or also fully engineering cancer cells, such as CAR T cells or CAR NK cells, to specifically attack tumor cells that have a certain cell surface protein expressed. So a lot of different opportunities now to leverage cell surface expression for therapeutic targeting. And I think this is where the expertise of pathologists and the relevance for pathology in drug development becomes so important. Now, in prostate cancer, there's one poster child, and that is PSMA. It's also known as prostate-specific membrane antigen, a protein that's expressed at very high levels in the vast majority of prostate cancer cells. And over the past decades, there's been a steady development of small molecule binders that can dock onto the external portion of PSMA. And these can then be loaded with different agents, in particular those that emit either beta or gamma radiation. And the nice thing about it is that with beta radiation, you can have a therapeutically active drug, whereas with gamma radiation, you can use the same type of small molecule for imaging, and this has been very effectively used over the past couple of years for both prostate cancer imaging, but also for prostate cancer therapy. Currently approved, this is just one drug by Novartis called Pluvicto, or its standard name 177 lutetium PSMA 617. I know it's a handful. So for the rest of the talk, I'll refer to Pluvicto for this particular therapy. And the initial therapeutic responses, and you've seen a scan from a patient pre-Pluvicto therapy and then post-Pluvicto therapy on the right, were pretty encouraging. And these are data now from the so-called VISION trial, which led to the clinical approval of Pluvicto. And you see that there is certainly a benefit in disease progression when patients are treated with this new radioligand therapy. But I think there's still a whole lot of room for improvement. And I mean, one of the biggest challenges that all of these cell surface-directed therapies might have in common is that the expression of the target really matters. So it's very nicely shown in preclinical models where you can titrate in the expression of PSMA in different cell lines and then engraft them into mice and treat them with this Pluvicto drug. And you start to see that the highest level of responses are seen in those animals that have the highest level of expression. And this was also shown in retrospective analysis in clinical samples using now PSMA-directed approaches for imaging as a readout for PSMA expression. And you start to appreciate that patients that have very high expression of PSMA do significantly better on this therapy. So this, again, calls out the importance of assessing tissue-based expression for all of these approaches. And I've talked a little bit about this before, but I just want to introduce a very unique resource that we have at our institution, which is a rapid autopsy program that was started more than 25 years ago. And in that program, patients who are treated at our center at the terminal stages of the disease are invited to participate, to donate their remains, to have a rapid tissue sampling performed right after their death. And this allows us to comprehensively sample the metastatic tumor burden in a patient. Often we collect more than 40 different metastatic sites. Since it is a rapid program with a postmortem interval that's in the range of 4 hours, the tissues that are collected are very high quality and lend themselves for multi-omics analysis. For all of these patients, we have detailed clinical histories, and we also make an attempt for every patient to engraft tumors as patient-derived xenografts. And this effort, which is truly a collaborative effort between many of us in the Seattle-based prostate cancer program, has led to a lot of different insights in the field. And this is also a resource that has been actively shared with many investigators across the world. But it allows us now to do very detailed expression studies, in particular of these cell surface targets that we are interested in. So here I'm just showing you now micrographs using a validated PSMA IHC assay and staining tumors of these different molecular phenotypes that I had introduced to you. And you start to appreciate that expression patterns greatly vary between those tumors that are AR positive and AR negative. Here's just a quick summary showing you the distribution of PSMA expression in this cohort, with a clear focus here on, first of all, the heterogeneity of expression of PSMA, but then also the almost complete absence of PSMA expression in these tumors that are AR negative neuroendocrine marker positive. But again, and this is where the tissue-based assessment is so important. when we look a little bit more closer at these tumors that are AR negative, neuroendocrine marker positive, you start to see that while PSMA is not expressed in the tumor cell compartment, you see very high level of expression of PSMA in the neovasculature associated with these tumors. And this has been described in many studies before, but again, highlights this need for tissue-based assessment for these novel therapeutic targets. Can now also use these rapid autopsy specimens to assess the heterogeneity of expression within patients. So this is a study published by Errol Consire a couple of years now ago, looking at the diversity of expression across different tumor sites. And here I'm showing you a patient with adenocarcinoma in a lymph node, neuroendocrine carcinoma in the liver, and sort of a mixed carcinoma in a separate lymph node. And you see that there's a high level of heterogeneity across these different metastatic sites. And this is also true in patients that are uniformly adenocarcinomas, with the case shown in the bottom showing very low expression in the lung, more heterogeneous expression in the liver, and then high level expression in the bone. So this is really helpful information to think about the future development of drugs targeting PSMA and certainly also other cell surface targets. I think this is one of the figures that really challenge the way we've been thinking about PSMA targeting. And this is leveraging now a larger number of cases from the rapid autopsy cohorts, 52 patients. Every patient is lined up in a column, and every metastatic site from a patient is shown with an individual dot, and the dots are then color-coded based on their molecular phenotypes. What you start to see is that there's a large number of patients, about 25%, that have no PSMA expression across all metastatic sites. This is strongly enriched for these cases that have AR negative tumor phenotypes. Again, shows the value of this molecular classification system that I had introduced to you. Then we have about 44% of patients that show highly heterogeneous expression of PSMA across different metastatic sites, with some tumor deposits having no PSMA expression, others have very, very high PSMA expression. And then there's a group about 41% where there's more uniform high expression of PSMA. So you see that these detailed tissue-based studies really reveal a previously unappreciated level of expression heterogeneity. And this is very important information for the development of these drugs. But what can we do in these cases that are PSMA negative? And this is just a small vignette that I want to end on with, where we used transcriptomic data from multiple different data sets, trying to understand whether there are other targets that are expressed at very high levels in these PSMA low to negative tumors. And the one that really sparked our interest was a surface protein called MUC1. We then performed extensive immunohistochemical validation of MUC1 and saw that a large proportion, almost 90% of the PSMA negative tumors, showed high level of MUC1 expression. And in IHC, you can see that there's almost this flip-flop pattern where when MUC1 is high, PSMA is low, and vice versa. And even in cases where you have a high level of admixture of PSMA positive cells and MUC1 positive cells, on the single cell level, shown here are some dual IF micrographs, you see a complete mutual exclusivity of the expression of these two cell surface targets in castration-resistant prostate cancer tumors. So this really suggested to us that potentially targeting MUC1 could be beneficial and could either be used as a co-targeting strategy or as a single target. So this is just very recent data that we collected together with a small biotech company, XY1, that's based in Boston, looking at the expression first of MUC1 and PSA in a large number of patient-derived xenograft models. We identified several that have high levels of MUC1 expression and complete absence of PSMA. We engrafted them into mice. And then we treated them with two different antibodies that specifically target the extracellular portion of MUC1 This is shown here as this MUC1C, and these antibodies are conjugated with two different payloads. One is a classical MMAE, the other one is exatecan. And you see in the growth curves to the right that treatment with these antibody drug conjugates leads to almost complete elimination of these PDX tumors, of these otherwise very, very difficult to treat PDX lines. Again, suggesting that an integrated approach looking for alternative targets that are expressed in certain subsets of prostate cancer can result in the discovery of new therapeutic avenues. And of course, there's a whole lot of additional work to be done in this context, but I think it gives us hope that the pathology-driven assessment of these targets can really lead to new therapeutics in the space of castration-resistant prostate cancer. So to sum it all up, I think the responsibilities of the pathologist in the future are constantly evolving. And I think the novel quantitative tools that we will have in hand will improve our diagnostic accuracy, but will also generate this wealth of additional data. And I think where I really see the role of the pathologist in the future is of a steward for molecular data, who helps bridge diagnostic and clinical care in a unique way. And if we think back what Rudolf Virchow had said to that, I think he would have really appreciated this dramatic change that our field is currently undergoing. Want to highlight a lot of the people that have been instrumental for this work, both in my lab at Fred Hutch and other centers around the country. And I really want to leave you with this, that a lot of these AI tools that we are deploying that can leverage image data can also be used for other more fun things, just like making a long gone pathology luminary dance. And with this, I want to thank you for your attention, and I'm happy to take any questions.
Thanks, Michael. That was amazing. While people are getting their questions ready, I wanted to ask a quick one, which may be obvious from the way that you had highlighted it, but that cribiform pattern where it's associated with poor outcomes in the context of primary prostate cancer, but then better outcomes in the context of castration-resistant prostate cancer. What is that cribiform pattern? Can you use these AI tools to inform like what it is, what its molecular features are, and potentially explain that dichotomy?
Right. Yeah, I think it's a fascinating question. We're just starting to sort of think about this a little bit more. For me, cribiform morphology as a whole just means that you have a lot of cells that are tightly adherent to each other. The hypothesis that I would have right now that in the context of metastases, you don't want to have cells that are tightly adherent to each other. There's a lot of interesting prior work suggesting that there are also major metabolic switches, especially in the central areas of these cribiform glands, where you need to have down regulation of certain metabolic pathways. MYC, for instance, is dramatically downregulated in the center of these cribiform glands. And maybe that is an important feature to have in the localized disease setting, but in the metastatic setting, this doesn't really make any difference anymore. So there's a whole lot, I think, to be further explored. But the point that I really wanted to make is that assessment of morphologies is important, but also seeing this in the context of where the tumor resides, I think is of great value.
Andy, do you have a question?
Sure. Thanks, Scott. Hey, Michael. Andy Nelson. I'm a molecular and anatomic pathologist here. Great talk. Thank you. And thanks for really kind of putting in front of all of the pathologists how important digital pathology is in terms of understanding biology. I had a question, and I apologize. I hope this isn't a dumb one because I did get pulled away during a portion of your talk for a clinical call. But one of your slides early on, when you were covering some of the molecular characterizations, showed methylation patterns in prostate cancer, which I don't actually know much about, but either the UMAPs or the Tisney plot showed very tight correlation of different subtypes based on those methylation patterns. Moving forward then with as we train out these AI models, both, kind of pick up on the nuances of the histologic patterns and other things, do you think that an integration of methylation patterns as well as outcomes will drive kind of the best overall large image models that utilize our routine histology to prognose?
Yeah, I think that's a great question because a lot of the work in our laboratory is really focused on DNA methylation. And a lot of the more basic biology work, again, is very much focused on understanding DNA methylation alterations. I think as a biomarker, it is exceptionally good. We've used DNA methylation as a biomarker, in particular in the context of liquid biopsies. I think it's just outstanding.
Yeah.
The one thing that you make a good point that having like a combined model where we use digital pathology and methylation analysis could be helpful, and I totally agree. But on the other hand, I think that a lot of the digital pathology analysis that we can do right now is so powerful that maybe we don't need to necessarily layer on top another molecular assay that would just add additional costs. Because I'm a big believer that we haven't even scratched on the surface of what's possible with H&E based diagnostics. And I'm very, I think, intrigued by this idea of cost savings.
Yeah.
And if you look at some of the other models that have been published recently, claiming that they can infer single gene expression from H&E alone, I think we'll get to a point where probably not single gene expression, but these broader molecular concepts will be probably read out by H&E morphologies alone. And this can then be tied very closely into DNA methylation alterations as well. So I overall think that DNA methylation is probably one of the more powerful molecular alterations that we can determine. But I would say we should probably do our best to extract the most information from H&Es. And this is hopefully where the future will go. And you see this already in some of the commercial applications that have been presented.
Yeah. Well, thank you.
Well, I think we're at time here. So, Michael, thank you very much for joining us this morning and for getting up early. I know that you're on Seattle time and this is early on Central time. But wonderful lecture. Thank you very much.
Thanks so much. Thanks. Bye-bye.
Bye.